Okay, today's topic is infertility. Infertility involves the possibilities of pathologies associated with either the male reproductive system or the female reproductive system, or more often than not, some sort of combination between the two. So defining infertility to start with is the inability to create a zygote, essentially. And that process is dependent on spermatogenesis and oogenesis. And we've talked about those two sets of steps in previous discussions. We want to remember that for spermatogenesis, it begins in a typical male at the time of puberty. And by definition, one definition of puberty includes sexual viability. So in this case, the male begins spermatogenesis to the tune of millions per day, pretty much throughout the rest of his lifetime. But that process requires several steps that we're going to talk about in just a minute as a reminder. Oogenesis, on the other hand, is a process that begins in females prenatally. And unlike the male system, which is all about proliferation of gametes, the spermatozoa, the female system is all about reduction. So beginning in about the 20 weeks gestation time or so is the time where a woman, a female, will have her maximum number of oocytes. Those are the cells that can enter into the process of oogenesis. From 20 weeks gestation to the typical birth time at about 40 weeks gestation, those numbers have been reduced at least by half, and often by half again by the time a female gets to her sexual maturation or viability, her puberty, which is usually beginning somewhere around 8, 9, 10 years of age. Typically for females, a couple of years later than that in males on average, with lots of variability in between. But these processes are complicated. They depend on a lot of environmental favor and also genetic functioning in terms of the processes, including mitosis and meiosis 1 and 2, and some other steps that are going to be required. So in a scenario where the creation of a zygote is not possible, there may be male reasons for that, there may be female reasons for that, or as I mentioned, often there's a combination of the two. So infertility in humans is defined as the inability to become pregnant after at least 1 year of unprotected and regular sexual intercourse involving the same male and female partner. There are going to be lots of different causes for infertility, including some that medical intervention can deal with. Worldwide, about 5% of all heterosexual couples have an unresolved problem with infertility. Many more couples will experience involuntary childness for at least a year, with estimates ranging much higher, somewhere in the 10 to 30% range. So in that respect, it can be permanent. It may be treatable. Or it may, in some cases, just be temporary. So when we look at male infertility, typically responsible, and again, these are not numbers that you're going to need to memorize for the purposes of evaluation, but male infertility accounts for somewhere in the vicinity of 20 to 30% of cases. And females, we're going to see in a few minutes a little bit higher than that. And another combination is due to combinations of problems with both partners. So let's actually, we'll write that down now just to get that out of the way. Female infertility is just a slightly bit higher range. Combination is higher again, as high as 40% in some research. And then there's a small percentage so these are which system is most likely to be involved with respect to an inability to achieve a fertilized state. So basically, when we look at male infertility, it's going to be most often due to deficiencies in semen quality. And recall, semen is made of nutrients that are going to improve both the viability and the motility of the spermatozoa. So if those nutrients aren't readily available, they can't be made available to the spermatozoa. So it's going to have a direct effect on the viability and motility of those spermatozoa. Or low production of the semen volumes, again, resulting in an inability to support those two primary responsibilities, motility and viability. But we can also see in males conditions where there's retrograde ejaculation. We should be comfortable with that term retrograde by now. Low levels of testosterone. You will recall that testosterone is stimulated by luteinizing hormone. The interstitial cells of Leydig are responsible for producing testosterone. If they're not adequately signaled by LH from the anterior pituitary gland, you're going to have low levels of testosterone. Testosterone directly stimulates spermatogenesis and supports the effects of FSH on the Sertoli or sustentacular cells. So lots of important roles for both the LH, but specifically the testosterone functions. We can have pituitary tumors. Again, pituitary tumors that inhibit LH production and release can lead to low levels of testosterone. You can have the general term is functional azoospermia, which is directly referring to the amount of spermatozoa that are available. So they're low numbers of spermatozoa. And you can have what's called obstructive a zoospermia in which the pathway for the spermatozoa is blocked for some reason. So remember that the pathway is the entire vas deferens or ductus deferens that's going to travel from the testes into the pelvic cavity, around the bladder, through the seminal vesicles, through the prostate gland to the urethra. So a blockage anywhere along that pathway would be described as an obstructive azoospermia. In females, when we look at females, the same concepts are going to apply. There's going to be some endocrine pathology. There's going to be some structural pathology. But as we know, the female cycle involves stimulation of two distinct groups of tissues, the ovarian tissues and the uterine tissues. So it's a little more complex as far as that goes. But the most common cause is age. So that's significant. So basically what happens as a woman begins to age is there are fewer and fewer follicles that contain primary oocytes that are going to be available for stimulus from FSH and LH. Is otherwise known as a reduced ovarian reserve. Some women will undergo a condition that's called primary ovarian insufficiency, which is also known as premature menopause, where there's a loss of ovarian function before the age of 40. So some other factors we're going to talk about as we move along in this topic are some endocrine imbalances or outright absences. So keep in mind that the pituitary hormones, FSH and LH, target the ovaries and create changes in those ovaries, including follicular development and the onset of ovulation. Those are two very important roles for the pituitary hormones to perform. In addition, those hormones result in the production of ovarian hormones, estrogen and progesterone, which have a responsibility for targeting the uterine endometrium, as well as many other targets throughout a female's body, resulting in, for example, the production of secondary sex characteristics, the development of mammary glands to become functional in the event that a pregnancy occurs, and all those other functions, again, that we reviewed very briefly, but you can review in the normal anatomy and physiology of the female reproductive system. So we'll look at a couple of those as we move along. The other thing to keep in mind is women who are fertile have naturally infertile So when we talk about natural infertility, that's the times in a female cycle where there is no viable egg available in the event that there were viable spermatozoa in the environment. So basically, if we look at a standard or so-called typical 28-day cycle, and by convention, we say day 14 is the day of ovulation. An ovulated egg has a viability of about 24 hours. So that would be to day 15, for example. And spermatozoa can survive and maintain significant viability in the female reproductive tract for about 48 hours. So if we put the male system into our little and just designated 13 and 12, this time frame right here is the ideal time for fertility. That's the fertility window, about 48 hours before ovulation and about 24 hours after ovulation. Some women may not ovulate on day 14. This is to illustrate the typical cycle. So we said in a typical cycle, it's about 28 days. The first 5 days or so is the menstrual slough. Then we have in the ovary proliferation, so-called proliferative or so-called the ovarian phase, or the follicular phase, I should say, where the follicles are developing with a goal of maturing one follicle each cycle, available for ovulation to occur on day 14. The second half of the cycle, from an ovarian perspective, was the luteal phase. The primary follicle, or the Graafian follicle that ovulated the egg and its surrounding cells, is going to be converted to the corpus luteum. That's an endocrine gland responsible for the production and the release of estrogen and progesterone, along with a couple of other hormones, relaxin and inhibin. And that will continue if there's a pregnancy, if there's fertility and then implantation, that corpus luteum will sustain that endocrine function for about the next 2 to 3 months. And eventually the placenta is going to take over. But from a fertility perspective, we're looking at this window with our understanding of spermatozoa survival. Now, can it last a little longer? Yes, but we're talking about viability and the ideal window for fertility. So this is the window that a couple that's trying to get pregnant is looking for, trying to establish the presence of spermatozoa in the female reproductive tract within 48 hours of ovulation, and with the understanding that the egg itself can survive for about 24 hours afterwards. So for those that are not interested in fertilization, this is the window to avoid. Now, about 85% of infertile Couples have an identifiable cause. And 15% is unexplained. Okay, so this is a pretty significant statistic. These are not numbers to memorize, but you can look at those numbers and you can say the vast majority of infertile couples are going to have an identifiable cause once they've undergone the investigative procedures. And the remaining 15% may never get a definitive diagnosis. Of these numbers, about 25% are due to some sort of abnormal ovulation. And of those, a big majority of those is due to polycystic ovarian syndrome, basically where the ovary does not bring to maturity any of the follicles with any kind of consistency. So there's an inability to produce a viable follicle that will then mature to ovulation. A smaller percentage are due to problems in the uterine tube. So what we're talking about there is there's some sort of structural problem in women of childbearing age, and it's possible that endometriosis plays a role here, or some inflammatory condition may play a role here. But basically, there's a possibility here of uterine tube pathology that leads to the inability of the egg to effectively travel down the uterine tube towards the uterus and to meet with spermatozoa in the first place. And then another percentage is directly related to an endometrial problem, endometriosis. Endometriosis is somewhere in the 25 to 40% range of female infertility. So what are the causes for infertility? There are a host of answers to this particular question. So first of all, there's what we call natural infertility. And natural infertility refers to the state of males and females before puberty. So pre-pubescent males and females are infertile. And that's kind of part of the definition of puberty. So if you're prepubescent, you haven't reached sexual maturity, you're not producing viable gametes, whether you're female or you're male under those circumstances. The gonads are not developing gametes that are able to reproduce. So the hypothalamus So basically, in the prepubescent state, there's no stimulus from the hypothalamus to trigger the production and release in the anterior pituitary gland of FSH and or LH. So without those influences on the ovarian tissue, there's no follicular development and there's no ovulation. There are scenarios where a child may become sexually viable early, and that's a condition that's called precocious puberty, most often caused by a tumor in the anterior pituitary gland that results in the production and release of FSH and LH. Now we can also have, so we have natural infertility. We can have a condition that's called delayed puberty. As the name suggests, it usually resolves, but delayed puberty is a situation where the sexual viability occurs a little later than average. In girls, it's often as early as 10 through about 14 years of age, and boys a little bit later. So basically, a girl is considered to have delayed puberty if she hasn't started menstruating by about the age of 16. So in females, if menstruation is absent by 16, and it becomes obvious too because there's probably also a delay in the development of secondary sex characteristics, which is often the first indicator that there's going to be a bit of a delay. Boys are going to be considered to have delayed puberty if they lack any enlargement in the testicles by about the age of 14. That doesn't necessarily mean that they're producing viable spermatozoa. But in boys, if testicle enlargement hasn't begun by 14, those would be the sort of measuring indicators for describing a delayed puberty. It's relatively rare, but it is a small percentage of adolescents who go through this. But it's also not uncommon for puberty to be delayed for several years and still occur normally. So often, once begun, is normal. Delayed puberty may often occur also for other factors, which will be fairly obvious, I think, too. Malnutrition. Malnutrition, there's a number of systemic diseases, genetic diseases, defects of the reproductive system, including hypogonadism. Endocrine pathologies. So when we think about malnutrition, we know that at least part of the puzzle for females as they approach puberty, sexual maturation, is there's a predictable, reasonably predictable percentage body fat that is required in order for menarche, for the beginning of menstruation to occur. And if women who are have a very, very low percentage body fat, maybe for reasons like anorexia nervosa or other factors that we'll address a little bit later on, they may not achieve that percentage body fat and may not begin the process of oogenesis effectively at the age expected. And so that accounts for a delayed form of puberty. So that was two. We also have immune for infertility. And in immune infertility, there are anti-sperm antibodies that can form. And these antibodies can form in both females and in males, but they're considered as part of a cause for infertility in a significant percentage of couples. So, and again, these antibodies can form in either the man or the woman, and they're going to target surface antigens on the spermatozoa. So they're going to target receptors, antigen receptors on the spermatozoa, create complexes that the immune system can recognize, and then introduce the immune responses, whether it's a T cell response or an inflammatory response that recruits the complement mechanism. But either way, it's going to render the spermatozoa ineffective. So it's going to reduce viability and due to immune responses. Sexually transmitted infections. So some of these we mentioned before when we were talking about pelvic inflammatory disease. We talk about chlamydia, and we talk about gonorrhea and mycoplasma genitalium. These are infections that will interfere with the female reproductive tract, and they're going to increase the risk for infertility. There's genetic mutations that occur that are found in a small percentage of men, for example, that where the cause for that genetic change is unknown, but it basically interferes with the viability of the spermatozoa. So we're not going to spend too much time on talking about those ones, but we can talk about some DNA damage. So DNA damage, not necessarily mutation. DNA damage is going to reduce in females decreases oogenesis and factors that can cause DNA damage including mutation. We know smoking, other DNA damaging agents like radiation and chemo. Some exposure to particular toxins that can also increase the possibilities of oxygen stress, good old oxygen stress, free radical accumulations. For example, this affects both males and females. Maybe I'll just put in the male thing first. So DNA damage can reduce fertility in males because it can, again, caused by oxidative damage, by smoking. Some of these same mechanisms are the causative agents, but they will reduce the viability. So we'll just say spermatogenesis by exposure to these same things. Okay, so for example, one of the big things that's been recognized in the last decade or so in particular, with its effects on general health, but specifically in our conversation right now, is the concern with fertility is exposure to PFAs. So the PFAs, the perfluoroalkyl substances, PFAs, is a better way for us to it's easier to say for us and easier for us to be able to talk a little bit about it. These are chemicals that are put into many, many different products that we're exposed to on a regular basis. And it's been recognized that fertility has been on an increase over the last decade to 2 decades from a significant perspective. So, for example, it's believed that the PFAs account for significant infertility issues to the tune of about an increase of about 40% in females, maybe a little bit less than that in males. But it's a significant factor. And these PFAs, they can disrupt follicularization. So what we know is exposure to these for females, they disrupt follicular development. They disrupt production and secretion of estrogens, they increase oxidative stress, and there's a whole bunch of things that they do, but I'm just going to say they also increase the risk of endometriosis. So that's what's going on in the female. In the male, basically the analogous functions are going to be affected. Spermatogenesis can be disrupted. The production and release of testosterone is going to be interrupted. The oxygen stress will minimize fertility as well. So all of those things are going to be affecting the male reproductive system at the same time. So this is a classic example where we are chronically exposed to these substances in our everyday lives to the degree that when they're put into waste locations, these PFAs don't degrade very easily, so they contaminate the soil. They contaminate our water sources. There have been research studies done that show measurable levels of these PFAs in our water sources. So these PFAs in our water sources, our soil sources. So these have implications to everything that we eat when they're found in those sorts of things, or the things that we eat that depend on water and soil, including plants and animals and so on. Many, many different household products. Some of those household products are like personal care, creams and sprays, personal care products, cleaning products, those sorts of things that were waterproof clothing. So there you go. Waterproof clothing is toxic. Found in carpets and paints. So often these things that we like to purchase for convenience comes with a price. Price is exposure to these PFAs. Now, every one of these products, the manufacturers will tell you that the quantity of these PFAs is so low as to not be recognized as toxic. And it isn't a single product that's the issue. It's the chronic exposure to those products and the cumulative effects of being exposed to many of these products. So these PFAs can damage the DNA. They typically are described as not causing mutations to DNA, but they damage the DNA, and that's going to alter the function of that DNA and its ability to promote normal functions with, in this case, with respect to the reproductive system, the result being infertility. So that's what we're talking about when we talk about exposure from environmental factors that can cause DNA damage. What letter are we up to? I can't remember what letter we had. That was E. Damage to DNA was our E, so this becomes an F. Hypothalamic pituitary factors, what we're talking about here are increases or decreases in levels of hormones that are part of this axis. Gonadotrophic hormones from the hypothalamus signal the anterior pituitary. If they are increased or decreased, we're going to have abnormal responses from the anterior pituitary gland, resulting in either more or less of the FSH, LH factors. We also know, so one consideration is the HPA, which is fairly straightforward because of its direct influence, but thyroid pathology also plays a role. Thyroid gland is responsible for overall metabolic rates and therefore has a direct effect on temperature. We know that in the case of the male that the testes is an environment outside of the core of the body that's slightly cooler. If we have hyperthyroidism, those body temperatures are going to rise. That's going to have a negative impact on spermatogenesis. So hyperthyroidism that's sometimes caused by autoimmune mechanisms such as Graves' disease, where we have in Graves' disease, we have antibodies that mimic the thyroid stimulating hormone. So the antibodies mimic TSH, thyroid stimulating hormone. If these antibodies are circulating and they mimic TSH, they're going to bind to the thyroid hormone, and that's going to create overactivity, hyperthyroidism. And because the antibodies are causing the hyperthyroidism, negative feedback doesn't apply. Normally, elevated levels of T3, T4 would cause a negative feedback effect on TSH, but these antibodies don't respond to that normal scenario. And the opposite is true, hypothyroidism. So that's hyper, and hypothyroidism can be caused also by a different type of autoimmune condition. It's got a name, a Japanese researcher's name associated with it, Hashimoto's thyroidism. And in that situation, the antibodies target the thyroid gland themselves, recognize it as non-self, and begin to destroy the thyroid gland. So, caused by antibodies that attack thyroid gland directly, we get destruction. So again, we destroy a lot of metabolic activity, but this is also a cause for infertility. The polycystic ovarian syndrome that I mentioned earlier is another one that would fall under this hypothalamic pituitary factor scenario. Ovaries only partially develop the follicles, so the ovaries are incomplete. They don't go through all their stages required for oogenesis. And there may be elevated levels of testosterone in the female that's having this polycystic ovarian syndrome. Iodine deficiency may cause infertility as well, mostly through its role of hypothyroidism. If we don't have enough iodine, we can't make enough of those. We can't make enough of the thyroid hormones, and so we create an effect on spermatogenesis in males and oogenesis in females. And then the environmental toxins, we talked about one of them and its effect on DNA, but we have these environmental toxins. So we'll put our PFAs in there because we've already talked about those, but also some toxins found in glues, in solvents. Some of these are also PFAs in nature, but similar. Tobacco, smoke, smoke toxins, I guess we'll just refer to them as that because there's so many of them. And tobacco smokers are about 60% more likely to be infertile than non-smokers. So that's a pretty significant number. Underlying diseases like diabetes or these thyroid disorders or adrenal diseases, they can play a role as well. Oops. I think that should not be E. That should be a G. So diabetes, we can include obesity here. We'll talk about that one in a minute. Actually, let's save that one for a separate topic. It's worth spending a minute or two on. But we do want to put in our adrenal pathologies here and other underlying factors that can play a role. So when we talk about body mass index, BMI, being too skinny or too overweight will both increase the likelihood for infertility. So if body mass index is too high or too low, it will contribute to infertility. Now, keep in mind, these are risk factors. They increase the possibilities of infertility. They don't guarantee it. But like I mentioned, if I indicated that smokers are 60% more likely to be infertile than non-smokers, that's a pretty significant factor. And obesity can play a role in both directions, or I guess I should say mass index can play a role in both directions. So when we look at obesity, it can have a significant impact on both males and females' fertility. In females, if the basal body mass index is greater than about 27, there's a 3 times increased risk of infertility. Okay, so again, these numbers, I don't want you to remember these numbers, but understand that when it reaches a certain point, there's a significant increase. So you can predict that if the BMI was a little bit less than 27, maybe it's not a 3 times risk, but it might be 2 times risk. So the point is that as we approach a BMI of 27, which is considered to be obese, then the risk of infertility increases significantly. In males, when the body mass index approaches 30, there's going to be a decrease in sperm quality. So the 2 features that we talk about with sperm quality are motility and viability. So we know that as the male approaches that BMI of about 30, that there's going to be reduced sperm quality and impaired spermatogenesis. That's obviously describing infertility. A high BMI in males is also associated with low testosterone levels. And there's a higher incidence of erectile dysfunction, which contributes to infertility as well. Now, in the scenario where an individual is low weight, this typically has a bigger impact on females. So a very low basal body mass index. That may lead to infertility as well. Common causes of someone having a very low body mass index that could cause infertility is from anorexia nervosa, other eating disorders, excessive exercise. There are many cases where elite female athletes, for example, who train especially for endurance activities, will have such a low body mass index, such a low percentage of body fat that they stop menstruating. By definition, if you stop menstruating, you're not going to be fertile. So that happens in excessive exercise scenarios, which is also sometimes described as a relative energy deficiency due to sport or training. And infertility in females that have a low BMI is often due to functional hypothalamic amenorrhea. And what we mean by that is stress. Stress can have a direct effect on the hypothalamic pituitary axis. And then more often than not, it'll be a combination of factors. And sometimes the clear cause is never that obvious as far as that goes. So how are we going to treat this? Well, as we know from our recurring themes, we like to treat the cause whenever we can find the cause. That's going to give us an increased chance, not just for management, but also for a cure. So treatment depends on the cause. But we may have to consider some counseling, especially if stress is a factor, for example, fertility treatments. And fertility treatments can include medications, may include in vitro fertilization. In cases of, for example, some types of endometriosis, then some surgery may be applicable. The drugs used are drugs that are designed to either improve the sensitivity of receptors to hormones or to improve the availability of hormones to those existing receptors. So some of these medications fall into categories of promoting the stimulation of follicles or the stimulation of the gonadotropic hormones from the anterior pituitary gland. So, for example, there's a medication that's called clomiphene, and clomiphene is a selective estrogen receptor. So in a selective estrogen receptor, it's going to be applied to those that aren't going through proper follicular development. So this may be for the woman that's got the ovarian syndrome, follicular syndrome. And the goal here is that because estrogen, this is a selective estrogen receptor modulator, and otherwise like a blocker. So it's designed to block the negative feedback from estrogen. Primarily on FSH, but also on LH. So you might remember we talked that as estrogen is on the rise from a developing follicle, low increases or low levels of FSH has a negative feedback on FSH and LH, which means that FSH no longer continues to stimulate follicles. The idea is that in a normal healthy woman, the mature follicle that's secreting the estrogen is mature enough to continue its development in the absence of FSH and or LH. But in infertility, that's not always the case. So if we can keep the estrogen levels even lower or absent or blocked, then we remove that negative feedback mechanism altogether. So the FSH levels will remain higher. There's another medication, and I'm just picking these ones to describe the role that they play more than the name. You guys, as healthcare providers, will know more about names of some of these medications, not necessarily these ones, but medications generally more than me. Letrozole is a medication that is known as an aromatase inhibitor. And aromatase is an enzyme that typically converts testosterone and other androgens to estrogen. So if it's an inhibitor, it's going to reduce estrogen levels. So a woman who's having trouble maturing follicles may have both of these medications applied. The one that's going to block receptors for estrogen, and the other one that's going to block the production of additional estrogen from androgens. So that in the so-called polycystic disease, there's going to be a higher ability under the medications to bring a mature follicle to term. Now, both of these will increase the possibility together. You get an increase in ovulation, but also possibly several. So that's referred to as multiple gestation pregnancy, right? Twins or triplets and so on. So these medications bring to maturity more than one follicle in many cases. So again, someone who's going through the infertility treatments is made well aware of this possibility. So there's other approaches, but again, in this situation, these medications are designed to influence the normal cycling of the FSH, LH from the anterior pituitary to the ovaries, from the ovaries to the uterus. So these two medications together are described as being ovarian stimulators. And the other thing to keep in mind is often with treatments, especially treatments that involve chemicals, medications, there's an increased risk or a price to pay. And so far, the evidence shows that most fertility treatments, and these medications in particular, have very, very low risk of developing, for example, breast cancer or ovarian or endometrial cancers. So they seem to be very low risk as far as that kind of thing goes. Now, in some cases, in vitro fertilization may be a treatment of choice. The mechanisms for in vitro fertilization have progressed significantly over the last several decades. Been going on for a while, but they are more and more successful. This process began in the very late 70s into the early 80s, became more readily available. But as time has gone on, as those decades have gone on, the last 40 years or so, there's been big strides made in success rates of this in vitro fertilization. Basically, the principle is that there's an extract, you extract from the woman from the ovaries, and the oocytes are then fertilized outside of the body. Which is what the in vitro refers to. So that's step one, that's step two. And then the fertilized eggs are reintroduced into the uterus. Those are the basic steps that are involved with in vitro fertilization. So this process can also be applied to couples that are infertile for other reasons, whether they are same-sex couples. They may want to use sperm or oocyte donors with in vitro fertilization, and then apply what are referred to as gestational carriers, which is a surrogate, in other words, that's going to carry the in vitro fertilized zygotes, hopefully, to term. And so, in situations where medical conditions, for example, cancers that destroyed spermatozoa or so on, then these types of techniques may be they're available at least for couples that are having trouble that might be somewhat unsolvable for medical or historical reasons in that individual. There's even a process called stem cell therapy that's being experimented with now, not readily available, but stem cells that can be provide the opportunity for a live birth in people who lack gametes. And also, again, could be applied to same-sex couples or single people who want to have children. In this type of therapy, artificial gametes are produced in vitro, so in a laboratory. In the case of spermatogonial stem cells, the transplant takes place in the seminiferous tubules with patients experiencing problems with spermatogenesis. This therapy can be used in cancer patients, for example. Ovarian stem cells can be used to generate new oocytes, which then can be implanted into the uterus. So that's where stem cell therapy may become of some value as it gets perfected. It's very, very experimental at this stage. So that's it.